All right. Good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound Case Series. Today, we're joined by Dr. Joseph Chin. Dr. Chin completed his undergraduate in finance and marketing at New York University and also a post-bac program in pre-medicine. He then completed his medical school at SUNY Upstate Medical Center, and then a PM&R residency at New York Presbyterian Hospital, Columbia and Cornell. He's currently the Sports Medicine Fellow at UCLA Harvard Medical Center, and today he is going to be presenting on ECU pathology. Right, Joseph, you can start sharing.
Okay. All right, and you can all see my slides?
Yep, that looks
okay, great. So today I'm going to speak about the Extensor Carpi Ulnaris pathologies that we can see. I was lucky enough to find a case within the short time frame that I was assigned this topic. So let me go to the next slide. All right, so a little bit of anatomy, the ECU anatomy. So this muscle originates at the lateral epicondyle as well as the posterior surface of the ulna. It inserts onto the dorsal base of the fifth finger and is innervated by the posterior interosseous nerve. When you have the forearm placed in pronation, it helps with ulnar deviation. And when the forearm's in supination, it helps with wrist extension. The ECU also provides dynamic stabilization to the dorsal-radial-ulnar joint. In terms of relevant anatomy, there's a subsheath here in colored in red that holds and secures the ECU tendon as it passes over the ulnar onto the insertion. This subsheath is also considered a component of the TFCC. It is the primary stabilizer of the ECU tendon, with the extensor retinaculum playing a secondary role. So my major case for today's presentation is on a 26-year-old right-hand dominant male. He has no past medical history, had a prior history of wrist injury from basketball. Recently, during a pickup game in basketball 3 weeks ago, he fell backwards and caught himself directly onto his hand. Since then, he has had ulnar-sided wrist pain, made minimal use of anti-inflammatories, and returned to his desk job, which required lifting traditional paper files weighing about 3 pounds throughout the day repetitively. His pain is provoked with any sort of lifting, gripping, and it is relieved with rest, bracing, and anti-inflammatories. On physical exam, his passive range of motion had full extension at about 80 degrees, flexion at 80, radial deviation of 10, reduced ulnar deviation at 20, with pronation at 90 and supination at 90. He was tender at a 6 dorsal compartment on palpation. He also had discomfort with resisted ulnar extension and ulnar deviation. He was tender at the TFCC at the fovea. Also tender at the first compartment, had a positive Canals at the carpal tunnel and at the cubital tunnel, surprisingly. This is his x-ray here. What I wanted to point out at the x-ray is that he has a negative ulnar variance. For some of the audience members, I have some friends here too, the ulnar bone is the bone on the right. It is lower than the bone on the left. And usually this is associated with diseases such as Kienbach's disease and ulnar impingement. Normally, if we saw a positive ulnar variance, you would more likely see a distal ulnar impaction syndrome, lunotriquetral ligamentous tears, and scapholunate dissociations. I was fortunate enough to find this case, but at this clinic, this is the ultrasound model I had access to. It was actually a 2006 ultrasound Logic E, so it's the first in the series. So it's a bit older, so the pictures a little bit grainier. So I apologize for that, but I was able to capture all the pertinent anatomy relevant to this case. I use a 12 megahertz linear transducer, as well as a 8 megahertz hockey stick for the upcoming images. So this is the dorsal compartment of the wrist. And when I label it, we have the Lister's tubercle labeled in L, which is our landmark. The second compartment, which contains the Extensor Carpi Radialis longus and brevis. The third compartment which has the EPL, and the fourth compartment containing the EIP and the EDC. I move on to the distal radial ulnar joint here, and in this case, there's no instability. What's important to note is that when you're evaluating the DRUJ joint or the DRUJ joint, you look for instability where you can stabilize the ulnar, and if you dorsally displace the radius over 0.5 millimeters, that would be considered unstable. You can also evaluate for things such as widening of the joint in cases such as Galeazzi fractures. That's something you look for there. The next area scan was the dorsal scapholunate ligament here. And here I have it labeled. And the scaphoid bone on the left, the lunate bone on the right. And then you have the dorsal scapholunate ligament pointed to with the arrow. So normally the dorsal scapholunate component of the scapholunate ligament is about 4 millimeters thick. There's an intermediate ligament that's usually fibrocartilage anatomically, and there's a volar ligament that's 1 millimeter. You can assess this ligament with clenching of the fist or radial ulnar deviation. If you find spreading or a tear here or widening of space, then you are concerned for dissociation. What can happen is if you have a scapholunate dissociation is that you have wrist rotational instability, possible development of dorsal intercalated segmental instability or DISI, and eventually a slack wrist where you can have advanced osteoarthritis of the radial scaphoid joint, capitolunate joint, and just all the carpal bones in general. What I have here is a view of the ulnar wrist. This is the best view I can get with this ultrasound. And here I labeled some of the anatomy. On the left side of the ulnar styloid, I have the ECU tendon running along the top, a little bit of tenosynovitis distal to the ulnar styloid above the ECU tendon. I see the articular disc with a possible ulnar styloid tear, the radius, the lunate, the meniscal homolog labeled in M, and then the lunotriquetral ligament between the lunate and triquetrum. The TFCC normally plays a role with axial stabilization. There's a lot of stress to this general area with any sort of pronation, supination. What I have here is a transverse cross-axis view of the Extensor Carpi Ulnaris proximal to the ulnar styloid here. No visible tear to the region. The ECU tendon is contained beneath the subsheath. There's no significant displacement with supination or ulnar deviation. What I did have to note is that there's a shallow groove for this tendon in this patient. On the right side of the diagram, I have a picture here, which kind of divides the ECU tendon into a dorsal compartment where it's more towards the radial side, and an ulnar compartment towards the volar side. Relevant, I guess, for surgical cases. This is another diagram which shows the ECU tendon being held in place by the subsheath. Again, this plays a direct role in stabilizing the tendon. And the extensor retinaculum is placed in blue. It's the dorsal fascia attaching to the radial styloid laterally and the pisiform and triquetrum medially. The deep surface of the retinaculum surrounds both sides of each of the 6 extensor compartments and contains a synovial sheath with visceral and parietal layers surrounding each of those compartments. So what I did here was label the ulnar aspect and the radial aspect of our patient's wrist. I created a distance between them labeled in A and B. What I also had was the dorsal component of the ECU tendon measured to the radius and created the mark AC. So using this ratio of AC over AB, I can do a percentage of displacement. I looked at multiple papers showing that the Extensor Carpi Ulnaris has greatest displacement when held in supination. Supination has the greatest displacement over a neutral wrist over a pronated wrist. And if you add flexion and ulnar deviation, that creates a greater displacement over radial deviation and extension. What's found in many patients is that in their dominant arm, you might see a 0.55 millimeter greater displacement in a dominant arm compared to their non-dominant arms. In asymptomatic patients, you might see displacement of 50% in supination or ulnar deviation, or about 45% with wrist flexion. Total displacement usually is about 5 millimeters in asymptomatic patients, and that would be considered in the realm of normal. I categorized it in 3 categories in terms of movement of the ECU. Displacement is defined as any movement of the ECU tendon less than 50% using this formula. Subluxation is if you use this formula and have the patient displace the ECU tendon about 50 to 99% of the distance, and a dislocation is over 99%. This is one of my attendings here at Harbor, and the first one shows a long axis view scanning the ECU tendon. And then the second picture is a picture where we're trying to replicate displacement of the tendon, where you have supination, and in this position you can ulnar deviate. And for some patients, that can really provoke any sort of subluxation or dislocation there. This is a nicer ultrasound. Unfortunately, I couldn't use it for the patient. That's a Fuji sinus we just bought for Harbor. Continuing my scanning, here I am looking at the dorsal ulnar cutaneous nerve branching off of the main ulnar nerve. Usually the duct nerve branches off about 5 to 8 centimeters proximal to the Guyon canal, and it supplies the dorsal medial hand and the medial first half of the 4th digit and the 5th digit. And then we have a beautiful Netter's diagram showing the dorsal, the duct branching up the ulnar nerve, and we'll talk a little bit about the superficial and deep nerve soon. What I have here is the Guyon's canal. I have the ulnar artery shown here, the main branch of the ulnar nerve diving in, the pisiform, a little hint at some of the hypothenar musculature. The proximal border would be the pisiform. Distally, you'll have the hook of hamate. The roof is the palmaris brevis, and the floor is the transverse carpal ligament. The ulnar nerve branches off into the superficial branch, which provides sensation to the palmar 4th and 5th digit. The deep branch supplies the hypothenar muscles, such as the abductor digiti minimi, flexor, and opponens digiti minimi, and the palmaris brevis. It also innervates a little bit the adductor pollicis the deep head of the flexor palmar brevis, the third and fourth lumbricals, and the palmar and dorsal interossei muscles. So in summary, my ultrasound case report, we're using a machine, the G-Logic E 2006 classical ultrasound model. We use a 12 millihertz linear transducer and an 8 millihertz hockey stick. The indication was fall on an outstretched hand, owner-sided wrist pain, pain with lifting. I was a sonographer. This location was done in Los Angeles. The dorsal compartments, second through fifth compartments were unremarkable. The dorsal radial ulnar joint was unremarkable without any instability with allotment testing. The dorsal scapholunate ligament had no gapping with fist formation or ulnar deviation, and a visible intact ligament. In terms of the sixth compartment, there was hypoechoic fluid superficial to the ECU tendon, distal to the ulnar styloid process with tenderness on sinal palpation. The ECU tendon had minimal displacement, maybe 1 or 2 millimeters from the ulnar groove. The ulnar groove was shallow. In terms of additional scanning of ulnar wrist, there's concern for possible TFCC tear at the ulnar attachment. The dorsal ulnar cutaneous nerve branched off the main ulnar nerve without any sort of localized entrapment or hypoechoic swelling of the nerve. The Guyon canal had an intact ulnar nerve with normal division of the superficial and deep ulnar nerve without any sort of entrapment. I also looked at presatricutal joint. There's no overt OA nor swelling. I didn't take a picture. I didn't save a picture of that. I wasn't satisfied with the picture for the presentation, and so I didn't include that in the slide. I did include the results of the MRI report. So basically, 1 week after casting with a must-do cast with a surgeon, the patient was placed on consistent oral meloxicam instead of intermittent NSAIDs. He already started feeling pain relief. He attained an MRI with a 1.5 Tesla ability. The image wasn't uploaded to our system, but the report read, they also confirmed a negative ulnar variance of 4 millimeters. A report confirmed a tear of the articular disc of the TFCC, intact scapholunate ligament, intact lunotriquetral ligament. They mentioned a mild medial subluxation of the ECU tendon from the ulnar fibroosseous tunnel. There's no tendinopathy, and the ulnar nerve was normal in size within the Guyon canal. A little bit of a palmar ganglion cyst, which I didn't evaluate for in the limited time I had with the patient. I want to thank you all for listening. A little bit of shout out to the different training sites at Harbor, Team DeWin, Kaiser, Beach City Orthopedics. I did include a bonus scan, dynamic scan, showing, I call this the snappy physical therapist. This is a therapist that had bilateral snapping of the wrist at the ulnar nerve, and she just helped me take a picture of her wrist with my cell phone as I reproduce her symptoms. So I'm just gonna play the video here, and bam, there you go. You see the ECU tendon. Actually, I'll call that actually more of a dislocation, relocation, hence the sensation of snapping, and then some rehab exercises. So thank you all for listening. I'm open to questions.
All right, thanks so much for going through that, Joseph. I think Doug has to hop off in a second here. Doug, did you want to make some comments before
Sure,
you?
yeah, Joseph, thank you for that. I'm going to let Brennan go over protocols and stuff related to how he approaches this. I just want to make a couple quick comments. So that the ECU is part of my dorsal wrist protocol. But, and actually, Brendan and I, we were discussing this. We both, it seems like we have a separate ulnar side wrist protocol. So in a sense, if I'm asked to evaluate an ECU tendon, I might do a ulnar wrist protocol but it is part of the dorsal wrist protocol. Let's say if I'm just asked to evaluate the dorsal wrist. And in the dorsal wrist, the retinaculum has bony attachments at every compartment. So first, second, third, fourth. The fifth is quite variable. But then the retinaculum, when it goes over the ECU, does not attach onto the ulna, as you pointed out, Joseph. It has actually a complex attachment, but its main attachment is onto the pisiform, with attachments onto the triquetrum and TFCC, if I recall right.
Yes.
And this configuration is important because that allows so much the pronation and supination we have without restriction. So what that does is essentially say that the subsheath is the main restraint to ECU instability. And actually, for your ultrasound nerds out there, there's a structure right next to the subsheath called the linea jugata, Jugata, which I can actually sometimes see with ultrasound. And these are longitudinal fibers adjacent to the ECU within the subsheath that also provides stability. And I've seen this in a dissection. And so the subsheath is you can make more conspicuous by just gently rotating pronated and supination. And by gently pronated and supination, then you'll see the subsheath that is under the retinaculum. So that's important. And so when I see an intact subsheath, then I know one is that if there is instability, it's probably due to laxity and not a tear of the subsheath that arises for ECU instability. And, I noticed you had that article up. I mean, it's been well vetted that up to 50%, sometimes even a little more, of subluxation is normal with supination in some individuals. Because the ECU is part of my dorsal protocol, I have learned over time that ECU longitudinal tears or clefts are very common. And so oftentimes when I'm asked to evaluate, let's say, radial side wrist pain or first compartment pain, and I get the subsheath as part of my dorsal protocol, it's not unusual for me to see some longitudinal tears as people get older. And again, so it just highlights the importance of making sure you're correlating your ultrasound findings with the patient's symptoms. And then the last thing I just want to say is, for whatever reason, the sixth compartment is fairly susceptible to inflammatory changes. And so I've seen a number of cases where ECU tenosynovitis, true inflammation, is one of the first presenting signs of inflammatory arthritis. And so it's also part of our inflammatory protocol where we do a survey of the wrist and hand for the rheumatology department. And the ECU is part of that because I will often see inflammatory changes within the sixth compartment. So those are just one of the comments I wanted to highlight.
Thank you, Dr. Hoffman. Very helpful and very educational there.
Yeah, thanks, Doug. I think you highlighted one of the things that I really wanted to, drive home with the ECU. When we're scanning this, it is normal for it not to be normal, and that's kind of my baseline assumption when I scan someone for an ECU-related problem. Is I would be surprised if someone has ulnar-sided wrist pain and doesn't have some ECU pathology. Jay Smith here several years ago looked at a bunch of asymptomatic athletes and found that like 75% of the tendons either had tendinopathy or split tearing in them. And those are young, healthy, in the 20 to 6-year-old age range people with no ulnar wrist pain. And so we know that that's normal. When we look at these, Doug, just from a protocol standpoint, as you mentioned, technically when you look at like the some of the guidelines on like what is a complete scan, there really isn't actually an ulnar sided wrist scan. And so I essentially have kind of morphed over time how I approach the ulnar sided wrist, and I do it a little bit based on clinical examination, but I also want to make sure I am including appropriate structures kind of a little bit further away. So looking at the radiocarpal joint, for example, and looking for arthritis changes or effusion or synovitis, things like that. I also, as you mentioned, Joseph, scanning across the other dorsal compartments, so the third, fourth, fifth, sixth dorsal compartments. I also move over to the volar wrist, and I typically look at like the FCU. I look at some of the joints that you mentioned, the pisotriquetral joint. I look at the TFCC meniscal homolog. This is something that we've had some discussions on at some of our ultrasound courses, and even locally here, we've looked at this. It's very challenging to reliably see the ulnar attachment to the TFCC. And so there are some different ways that you can try and position the wrist to, shoot inward towards the fovea, and then get into the ulnar aspect of the TFCC to try and, evaluate that. But it's pretty challenging to make a really definitive call on ultrasound, at least at this point. I'll also, make sure I look at some of the extrinsic wrist ligaments. And so you had mentioned the scapholunate ligament, but you can move over and look at like the lunotriquetral ligaments as well. I also look at, like you mentioned, the DRUJ, and I do also check for stability of that DRUJ, and I compare that to the contralateral side. That's something that I have not, I've tried on some of our patients to try and quantify like how much motion of the DRUJ is normal, comparing it to the contralateral side if they're asymptomatic, but that's been challenging. I'd be curious, if Doug or Ryan or anyone else on the call has a better way to objectify, instability of the DRUJ. And then lastly, getting to the ECU tendon, just a couple of things to mention is, it is normal to have subluxation. A high percentage of people have some subluxation of that ECU. We compare that to the other side, especially if the other side is asymptomatic. And that relative difference from side to side is very important. So if someone has a very stable ECU on one side and a very unstable ECU on the other side, correlating with appropriate symptoms, I'm more likely to think that's really pathology and not just an asymptomatic finding, because frequently you do see that symmetrically. And then really focusing in on the structures, we know that when people get into hypersupination, that subsheath becomes lax compared to when people are in pronation or even in neutral, which is what allows people to sublux a little bit, even in the setting of there not being a tear in that. So just making sure that you're kind of assessing whether or not that subsheath remains intact as people go into the supination, I think is very important. And the contralateral comparison, I think, is essential. I put zero weight in an ECU dynamic scan that doesn't have a contralateral comparison. I think that's really one of the keys for ultrasound in this particular area.
Hey, Brendan.
Yeah.
Will your surgeons operate on an ultrasound for ECU, let's say, instability without an MR, or do they like to see the TFCC before they operate?
Yeah, so they like to see the TFCC in addition, because oftentimes if there's concomitant pathology, they'll address that arthroscopic along with the ECU. And just for example, on Tuesday, I saw a lady that has a ton of ECU pathology, but her symptoms are not ECU. She's got a big longitudinal split tear. Her tendon, actually half of it dislocates and half of it stays in the groove when she supinates, but she's not symptomatic at the ECU. So they're doing surgery on the TFCC and leaving the ECU alone. And so certainly, just because it's there doesn't always mean it hurts.
Right.
Yeah, so they are typically getting an MRI to look at the TFCC in addition to the scan. And even the patients that they see with an MRI already performed, they typically send them over for a scan before they operate.
Do you go for an MRI arthrogram at that case, or do you just do an MRI without contrast for the TFCC?
We do MRI without contrast, 3 Tesla typically.
Okay.
Yeah, I think if it's a 1.5 Tesla MRI scanner, most people are doing an arthrogram at this point.
Nice.
Two more comments I had on some of the images, and then I don't know if Ryan has anything to say as well. But when you talked about ECU tenosynovitis, I think we need to be really careful about how we use our words describing the tendon and the peritendinous soft tissue.
Okay.
If there's truly fluid around the sheath and hyperemia, in hypertrophy of that soft tissue, I think I'm more likely to call that tenosynovitis, as Doug was kind of alluding to. If it's just thickening of like the subsheath or the sheath, for example, that can also be seen with a sprain. So in your athlete with an acute injury, when you sprain a ligament, sometimes they thicken. And so I try to be careful about calling something tenosynovitis without kind of, maybe a couple of different findings in that. Not to say that isn't, but just making sure that you're using your some form of a Doppler imaging, whatever your machine supports, to look for slow flow blood supply, and then also kind of looking, is there fluid and kind of hypertrophy of that soft tissue is helpful. And then the last thing I'll say is on the Guyon's Canal image you had mentioned that the palmaris brevis forms the roof. On that image you had, it's hard with a one static image. I would argue that was perhaps an accessory abductor digiti minimi muscle. Usually the palmaris brevis is a bit flatter, and when you're looking at a muscle that runs obliquely across, from the distal forearm fascia across Guyon's Canal and then to the hypothenar hand, that's oftentimes an accessory ADM. So just being aware of that anatomic variation as well.
I like that. Very helpful detail. Thank you.
Ryan, do you have anything to add? Or Doug, any corrections?
I guess no, not really. Only one thing I might just mention, and Joseph, you may have said this, and if you did, then disregard. But anytime I'm looking at these tendons, or I guess nerves, for that matter, dynamically, for ECU, we'll see these, subluxation events fairly commonly, and in addition to dislocation events. In your report, I always comment on whether or not that was smooth subluxation or dislocation versus dyskinetic, for the ECU, as well as ulnar nerve at the elbow, or like I said, any other tendon or nerve. I think that's helpful because those are, I think, different problems. And I feel like the dyskinetic motion, dyskinetic snapping, for the most part, generally speaking, tends to be more symptomatic than smooth, non-dyskinetic snapping. So that's the only comment I guess I would make.
All right, thank you so much, and thanks again, Dr. Chin, for presenting. We will be back in a couple of weeks. On February 24th, we have Dr. Christopher Collin presenting on distal clavicular osteolysis. So we'll see you guys back in a few weeks.